Good afternoon, everyone. Can you hear me at the back? Do my best to project anyway. So I'm Leon Green. I'm a Principal Public Health Intelligence Analyst at OHID in the North East and Yorkshire Local Knowledge and Intelligence team. And I'm going to tell you today about some work we did looking at stroke in South Yorkshire and Bassetlaw, and this was a collaborative piece of work with some of my colleagues from the Integrated Stroke Network and from the ICB in that part of the world.
The clicker's
Is
working.
the clicker working? Right, let's try. Thank you. So what we were trying to do was to provide some input into strategy development, looking at inequalities in stroke, and looking at within area variation and areas where there might be greatest potential for improvement. They had also moved to some hyperacute stroke units, and looking at the impact of those. I'm not going to say very much about the hyperacute stroke units today. I'm going to leave that for people with a little more expertise. So just a bit of background. South Yorkshire and Bassetlaw has an overall population of about 1.5 million. In light of our previous talk, I hesitate to say that we had about 87% white British population, about 5% Asian British, and about 3% Black and Black British populations. Centred around the main city of Sheffield here, but covering the 4 other areas, either CCGs or local authorities, which at that time were co-terminus. The left-hand chart shows deprivation from IMD, so overall a more deprived population than England on average. So we have about 20% of the local population who are amongst the 10% most deprived nationally, and a much smaller proportion in the least deprived categories. We looked at some stroke risk factors, so it's just from routine data from Fingertips platform. So hypertension, and we can see that the prevalence of all 3 risk factors here is significantly higher than England. Hypertension kind of fairly stable, atrial fibrillation tending to increase, and smoking rates tending to decrease. So a sort of mixed picture in terms of what's happening for risk factors. We dug down into the risk factors by primary care networks as well. So the different colours on here represent the different CCGs involved, with the England bar at the top. So we see essentially hypertension varying from about 12% to 18%, ignoring the university practice that's at the bottom of all 3 of these charts. Atrial fibrillation going from about 1.5% to 3%, so a sort of 2-fold variation, and then smoking rates varying from about 8% up to 23%, so more variation in smoking than the other risk factors. We took the PCN level data, primary care network data, and highlighted the top 5 for each of the risk factors here. So they could do bespoke work on each of the risk factors in each of the top 5 PCNs. But then we also added up the risks. So we created an overall risks metric, looking at the rank of risks, and highlighted the top 5, which you can see on the top left corner in grey. And then we correlated those with stroke prevalence from primary care data as well, and they don't correlate very well, which was a bit of a surprise to us, but there are ongoing theories into why that might be. Looking at routine data in terms of stroke admissions. So we can see for all of our CCG areas that the smoke admissions are above England, tending to fall a bit in Sheffield and Doncaster and go up a bit in the others. And the orange line, which is Bassett Law, sort of going from a little bit below to up towards the top over that 10-year or so period. We used SHAPE, which is Strategic Health Assets Planning Environment or something like that. I can't remember the full acronym, to look at the geographic distribution. So this looks at the top quartile of practices and where they're located. We can see very few in the bottom right corner in Bassett Law, and in general very few in the sort of town and city centres as well, so tending to be a bit more distributed in suburban areas. Stroke admissions, here Barnsley very much stood out, the blue line at the top, so quite a bit of variation around the England for the other areas, but definitely something different happening in Barnsley that kind of they weren't particularly aware of, we weren't particularly aware of at the start of this work. Also routine data looking at stroke mortality, and again Barnsley standing out here with 5 of the 8 indicators showing significantly worse than England. Some of those person level broken down by age groups, and some are males versus females. We summarised the risks, admissions and mortality in spine charts in fingertips, so you can select your own choice of indicators, and that's a summary for the network, and we also did it by the CCGs here. What we did notice on the side nearest to me is Barnsley, again showing a lot of red indicators, which we noticed was sort of driving the overall lower performance for the network as a whole. We moved on to do some more bespoke analysis using hospital episode statistics data. So this is covering a 5-year period and the relevant ICD codes there. Just over 15,000 admissions over that 5-year period, and cerebral infarction being the most common the codes identified. Look at those collectively and by deprivation. So we have the most deprived nearest to me and the least deprived furthest away from me, and a very nice social gradient apparent there. So these are age standardised admission rates, and higher than average in the most deprived groups, particularly deciles 1, 2 and 3, and then less deprived groups 6, 7, 8, 9, 10, significantly lower than the network average. And the chart on the far side from me showing male admissions tending to outrun female admissions by some margin as well. We went on to look at age breakdown. So this chart shows deprivation scale again from most deprived to least deprived, and ages at admission. So the median age showing a 6-year difference between the most deprived and least deprived groups, but when we looked at the lower quartile, a much bigger difference, so 12 years, so 25% strokes in the most deprived group are happening below age 57, whereas below age 69 in the least deprived group. So quite a big difference at the age of strokes are happening. We broke down those stroke admissions into MSOA areas, so they could begin some more targeted work, and this then linked through to the local health platform as well, so look at the demographics of those MSOA areas. Moving on to look at mortality, same ICD codes, 5-year period, slightly different, looking at calendar years rather than financial years, for reasons of how the data was structured, and just over 2,700 stroke deaths recorded over that 5-year period, slightly more females than males, and about 2/3 of them aged over 80, but still a significant proportion of under 65 stroke deaths. Similar sort of analysis to the admissions, so a very strong social gradient again in terms of deprivation, significantly higher in the more deprived groups and significantly lower in the less deprived groups. The chart on the far side showing Barnsley significantly higher than elsewhere in the stroke network, so none of the other areas were significantly different. The age group analysis again showing strokes happening at younger ages in the most deprived areas, and probably a slightly subtle difference, but it tended to be the least deprived areas that fared considerably better than the rest of the distribution here. But big gaps again, so the lower quartile here, a 9-year difference, slightly smaller than there was in the admissions data. Similarly, looking at this small area data, and so what we did was create this system response. So the first result was being challenged by local people as to surely this can't be right. The fairly typical data grief kind of type approach, but they're then looking at their own data and presumably will find this backs up the findings we got. It's been presented to ICD board and the stroke delivery group to get that sort of buy-in from leadership. Because of the data highlighting Barnsley, a task and finish group started there, and local plans being put in place, both at a neighbourhood and a primary care network level. And my colleagues are working on some sort of awareness raising in local schools and producing some work with local charities. So just a quick summary there of what I've told you about, and some sources there of data, so happy to take any questions if we have time.